respiratory in Charity, where Sarah will be taking the stage. We kindly inform that all speeches will be limited to a time frame of 20 minutes, followed by a Q&A session.
Right. Good morning, everybody, and thank you very much for giving me this opportunity to start the symposium also in this joint regional symposium. So my topic in this forum is to discuss what is new in asthma and COPD. So within the next 25 minutes or so, I would try my best to discuss the new updates in the management guidelines of asthma and COPD. And see how we can incorporate these things into our practice as well. So as you might already be aware, the guidelines that we follow for asthma is the GINA guideline, the GINA 2024 guideline, which is talking a bit about GINA. GINA stands for Global Initiative for Asthma. It is a guideline which is updated every year. There's an expert panel from members all around the globe who looks into the best cumulative evidence, and they form the guideline, update the guideline every year in line with the World Asthma Day. Right. So the recent 2024 update was issued a couple of months ago in line with the World Asthma Day in 2024. And the second guideline is the COPD guideline. In COPD, the guideline we follow is the Global Initiative for Chronic Obstructive Lung Disease, or the GOL guideline. And as the GINA guideline is updated along with the World Asthma Day, the GOL guideline is issued in line with the World COPD Day. So the World COPD Day falls in the month of November. So in 2023 November, the 2024 update goes out. So right. So I will start with asthma. So one of the key change that happened in 2021-2022 rather is the update in the terminology in the asthma, and this new concept of anti-inflammatory reliever concept came into the picture. So as you already know, for years our reliever has been in asthma, our reliever has been the short-acting beta agonist, or the SABA, or the salbutamol reliever. But then people found out that when we are giving salbutamol alone, or pure SABA, the asthma mortality goes up, or the exacerbation risk goes up. The reason is simple. We know SABA is short-acting beta agonist, and or salbutamol. If you are going to give the patient a SABA alone inhaler, we will always take it. So there will be down regulation of beta-2 receptors. And whenever a patient goes into a severe exacerbation, when you give the salbutamol or the SABA alone, it might not work. So the patient might go into a severe exacerbation and even die. So exacerbation risk goes up, and also the mortality also went up. So then people also need that asthma is a chronic inflammatory disease, and the chronic inflammation is there throughout the disease.
It's so sweet. That recipe consultant has sent me the meeting.
Even in the early disease, step 1 or 2, that's why even. So and the anti-inflammatory component has to be always healthy, and whatever anti-inflammatory drug should be there, even the relievers. So we'll see what these anti-inflammatory relievers are. So you need to have an inhaled corticosteroid plus a rapid acting bronchodilator. The combination will form the anti-inflammatory reliever. So as a rapid acting bronchodilator, you have two options, either to, what the Gina says, either to use a formoterol. Formoterol, mind you, is a long-acting beta agonist, but it has a relatively rapid onset of action. Or else you can use your conventional SAMA, short-acting beta agonist, which is a salbutamol. So you have two options here, either to combine ICS with formoterol, where you get the ICS formoterol combination, or else you can combine the inhaled corticosteroid with SABA, where you get the ICS SABA combination. So from 2022 onwards, the relievers, the preferred relievers are these ICS, these anti-inflammatory relievers, which are ICS SABA or ICS formoterol combinations. So the next update in terminology is in the maintenance therapy. So as you all know, maintenance treatment in asthma is the treatment that we give on daily basis to our patients to control their disease. But if the patient does not have symptoms, they have to take this maintenance therapy. So for years, our maintenance therapy has been inhaled corticosteroid containing medication, either ICS monotherapy, ICS LABA dual combinations, or ICS LABA and LABA triple combinations. And leukotriene receptor antagonists, montelukast, and biologics also comes under this maintenance therapy, mind you. So now, this is the maintenance therapy that is targeting the both domains of asthma control, that is, they target the symptom control as well as reducing the risk. And
Are you
reliever therapy is the medication that you give on an as and when needed basis for the quick release of relief of asthma symptoms. Previously, it has been SABA. Now we are moving on to these anti-inflammatory relievers, as I've told you before. So it should be ICS format ICS SABA on as needed. So then the next important new terminology comes, the MARC, which is the maintenance and reliever treatment.
I want to go.
So this is where the ICS formoterol combination is used, should be used both as daily maintenance of asthma as well as a reliever to be used on as and when needed basis. So you can use a single inhaler of ICS formoterol now as a maintenance treatment for the asthma control as well as the reliever. Also, you can use the ICS formoterol. So this is what you call the SMART treatment now, or single inhaler maintenance and reliever treatment. SMART. We'll see what this is in a moment. So, as you probably be aware, GINA guideline gives us a stepwise management of asthma treatment. So, in 2022, there had been a change in this stepwise pathway of asthma. They introduced two tracks of treatment. Track one being the preferred, track one being the preferred pathway, and track two is also there, which I will show you in the next slide. So
please mute your mics.
Please mute your mic, please. Mute your mics.
okay, sorry for the interruption. Yeah. So as I told you, so now we have got two tracks of treatment. The track one being the preferred pathway, where you get a preferred control and a reliever. And in this pathway, the reliever is as and when needed low dose ICS formoterol, which is the reliever. And there's in the stepwise pathway, the step 1 and 2 are now combined. Where in the first two steps, what you need is to give a as needed low dose ICS formoterol on an as and when needed basis. So this is the patients that I mean, if the patients are having very less symptoms, maybe symptoms less than 4-5 days a week, like if your patient is not controlled on that step, you have to step up to step 3 straight away, because 1 2 are now combined, where you give a low dose maintenance ICS formoterol, and mind you, the reliever is also the low dose ICS formoterol, so it's a single inhaler now. And if the patient is still not controlled, then you can have to step up to step 4, where you increase the dose of ICS formoterol as medium dose maintenance ICS formoterol, and still the reliever is low dose ICS formoterol. In step 5, if patient is not controlled on step 4, then you have to move to step 5, where you have limited number of options, where you can add a long-acting muscarinic antagonist or a LAMA to the current ICS formoterol dose, or else, I mean, ideal way is to refer the patient to a phenotypic assessment, because now we are talking about this phenotypic assessment of asthma, and biologic frequency. But so all throughout this stepwise pathway, the reliever is as needed ICS formoterol. So this is the preferred pathway. So the second pathway is the alternative pathway. Gina always gives us a second option, where the track 1 is not practical, or it's not. I mean, it cannot be practiced because of practical reasons. Maybe like in our settings, because we don't have ICS formoterol in the government sector. So the track 2 is there, where you have an alternative controller and a reliever. So here the reliever is as needed ICS SABA. So remember, now this is inhaled corticosteroid plus SABA combination. There are combinations like that, or else you can give as needed SABA also. But the point here is you can't give SABA alone, even in step 1, because if you are using SABA alone, you have to always take an inhaled corticosteroid dose at the time you are taking the SABA or the selectable inhaler. SABA or pure plain SABA has no place in asthma from now. So that is step 1. In step 2, this is the low dose maintenance ICS that you give on a fixed regular basis. And if the patient is not controlled, then you go on to step 3, where you give low dose maintenance ICS LAMA combinations, like the salmeterol fluticasone combinations that we have here. If the patient is not controlled, you step to step 4, where you give a medium or high dose ICS LAMA combination. And if not controlled, like in the previous track, the step 5 is the same. Your options are either to add a long-acting muscarinic antagonist or tiotropium, or else to refer the patient to step 5 phenotypic assessment to start biologics if they are available. So now in this pathway, the reliever is as needed ICS SABA combination, or else as needed SABA. But if you are using as needed SABA, you always have to give a ICS dose whenever the patient is taking the SABA or the salbutamol reliever. So again, summarizing the track 1, the reliever is as needed ICS formoterol here. This is what you call air anti-inflammatory reliever. And in the step 1 and 2, the first 2 steps, what you practice is air only or anti-inflammatory reliever treatment only. And in step 3, 4, and 5, or step 3 to 5, what we practice is what we call the MART treatment, or maintenance and reliever treatment with ICS formoterol in a single inhaler. So you can call it SMART, single inhaler maintenance and reliever treatment. The alternative pathway reliever is as needed ICS SABA combination. So that is the inhaled corticosteroid plus the salbutamol combination. They are also not available here. But you can use your plain SABA along with the ICS in step 1. That you have to take both inhalers, 2 inhalers in that case. So, what about thiopidins and leukotriene receptor antagonist or montelukast? Because before 2021, there was a place in the main stepwise pathway for these drugs, but now it seems that their presence is now getting a bit low, or I mean, they are moving very down the guideline, like they are mentioned in very small font, not given much weight, their place is slowly moving out. Like so, leukotriene receptor antagonists and thiopidins as control options are the evidence are now low. So, what are the evidence for this new ICS formoterol combinations? So these are the evidence that came up that when you are using ICS formoterol as a reliever compared to a plain salbutamol or a pure SABA inhaler as a reliever. This is what I told you in the beginning, that there's the risk of exacerbation goes down. There was a 55% reduction in risk of brain bleeding, and also there's from mortality, and the emergency department visits also go down. And this is the evidence for track 1. And this is the evidence for the marked treatment or maintenance and reliever treatment with a single inhaler of ICS formoterol as the reliever and also as the maintenance treatment. And again, it was shown to be superior to the ICS GABA combinations, where the asthma, the exacerbation risk and the mortality goes down. So, right. So, in the track 1 has a low dose ICS formoterol as the reliever therapy on as and when needed basis. There is a summary. And there have been multiple randomized trials showing the superiority of this ICS formoterol as the reliever, superior to SABA in reducing the exacerbations as well as the mortality. And now this approach is more simplified because it's a single inhaler. Because a single inhaler can be used as a reliever as well as the maintenance treatment for the smart therapy. Gina continued to give us guidance on how we can practically do this ICS formoterol in the smart treatment. So what they recommend is to use the budesonide formoterol 206 inhaler. You might be aware that we have 406 also. So the 206 inhaler is the one that they prefer. So in the first 2 steps of step 1, 2, the combined, that is in the track 1, where you practice air only, you can give just 1 inhalation as and when needed basis, like this is an example. In step 3, you can give 1 inhalation of ICS formoterol or formoterol budesonide or declarason budesonide, both you can use on twice a daily basis. In step 4, you can give 2 inhalations of twice a daily basis of ICS formoterol, either budesonide formoterol or declarason formoterol. And in step 5, again 2 inhalations twice a day. So the point here is you use a single inhaler, the same inhaler of 206. It is the number of puffs that you increase. You don't change the inhaler even. So the recommendation is to increase the number of puffs as you go up in the stepwise pathway. So what is the maximum number of puffs you can give is the next question. So if you are using a 206 inhaler, what the guidelines recommend is if you are going for the budesonide formoterol combination, you can give up to 12 inhalations a day in an adult and 8 inhalations in children. So this is for both as the maintenance and as the reliever, because now it's a single inhaler. If you are going by the budesonide formoterol, the maximum puffs are 8. So how the new guidelines can change our approach in managing asthma and limitations in our settings. So now, as we know now, SABA alone or salbutamol only treatment has no place now, and it's not recommended even in step 1 or 2. And as needed, low dose formoterol budesonide is the preferred reliever now. But as I told you before, that we don't have it in the government sector, so there's a limitation there in practicing the track 1. ICS SABA, which is the reliever in the track 2, still we don't have ICS SABA combinations in this country, where we don't get salbutamol along with metronidazole or budesonide combinations. But I think we should get them down. But still we can use SABA, plain SABA along with the ICS as a second inhaler. So there's practically there are issues in practicing the smart therapy. I mean, you can do it in the private sector if you the patient or budesonide for withdrawal inhalers. But again, you have to advise the patient that it is a single inhaler that we have to use as the maintenance and the reliever. And there's nowadays evidence for other control options like your primary antagonist and like montelukast and the opinions in the control pathway. Moving on to the second part of my talk, much to the updates in the COPD as well. Now COPD, the definition has changed recently, which I wanted to highlight. So in 2022, rather the core definition of COPD, which I think you already, this is the definition that we've been learning over the years, that COPD is a common, preventable and treatable disease that is characterized by persistent respiratory symptoms and airflow limitations that is due to airway and or alveolar abnormalities, usually caused by exposure to noxious gases, particles, so gases, and plus and influenced by host factors including abnormal lung development. In 2023 and towards 2024, the definition of the COPD has changed. Now it's defined as a heterogeneous lung disease or heterogeneous lung condition, as in asthma. Now, as you all know, asthma definition also has changed. Now they have introduced this term heterogeneous. Because all airway diseases are heterogeneous, they are not similar. One asthma is different from another patient's asthma, and one COPD is different from another patient's COPD, so they behave differently in different individuals. So COPD is also the same as asthma. It's a heterogeneous lung disease, lung condition characterized by chronic respiratory symptoms. They have given more emphasis on the symptoms with dyspnea, cough, sputum production, and exacerbations, and this happens due to abnormalities of the airways, either bronchitis or bronchiolitis, and abnormalities of the alveoli like emphysema, and that causes persistent and often progressive airflow obstruction. So the key or the important terminologies here are asthma being a heterogeneous lung condition, and it could, COPD being a heterogeneous lung condition, and it causes persistent and often progressive airflow obstruction. This is the proposed taxonomy for COPD. They have given etiotype or etiotype based classification for COPD in 2023, which I will show you. Now there's an entity called COPDG where you get your your genetics conditions like alpha-1 antitrypsin deficiency. This COPD is now termed as COPDG, and COPD-D is COPD due to premature birth or low birth weight and due to problems in lung development. Then we have COPD-C, which is the one that is common and associated with tobacco smoke or associated with vaping, e-cigarettes and cannabis. COPD-P is COPD due to exposure to pollution, either indoor or outdoor pollution. And COPD-I is COPD due to recurrent infections like in our settings, post-TB. COPDs, we see a lot of patients like that. So there's a entity called COPD-I in that case. And COPD-A is the COPD and asthma overlap. Now the ACO or asthma COPD overlap term is no longer used. Now it is termed as COPD-A. And then we have COPD-U, like CKD-U. Now there's a term called COPD-U, where COPD due to unknown origin. So another two important terminologies that have come up are the pre-COPD and the PRISM. The pre-COPD is the Now, this guideline, this new goal guideline gives us an opportunity to diagnose COPD early, because now we see some patients, they don't fulfill the criteria spirometrically, but these patients, they have a tendency to develop COPD later. So therefore, they have to be picked up. Like, so pre-COPD, some individuals who have respiratory symptoms, plus they have some structural lung lesions like emphysema in their CTs, and there are some physical abnormalities like gas trapping, hyperinflations, and diffusion defects in the spirometry, but they don't show the classic post-bronchodilated FEV1 FDC ratio of less than 70%. In fact, the ratio is over 70, but still you have to diagnose them and, as pre-COPD. And PRISM is the other term where PRISM stands for preserved ratio and impaired spirometry. The FEV1 FDC ratio is preserved, but still they have spirometric abnormalities like low FEV1s, and this is term called PRISM. And PRISM and pre-COPD are now taken as precursors of COPD, and they have a chance of going into COPD. So COPD, the ABCD assessment tool also has been updated. So till 2022, we were talking about this ABCD assessment tool. I will rush through because of the time constraints, where you first confirm the diagnosis of COPD by spirometry, and then the spirometrical grading is by the post-bronchodilator FEV1 as goal 1, 2, 3, and 4. And then depending on the symptoms or the exacerbation risk, you go into goal groups. This probably you might be knowing this because these things have been there for years in the goal guideline, where you categorize them into goal groups as A, B, C, and D, depending on the symptoms and the exacerbations. Where if your patient has less symptoms or less low MMRC of 0, 1, or CAT score less than 10, then they probably be in the AOC group, and if they have more symptoms, they are in the BOD group. And similarly, depending on the exacerbation risk, if the patient has less exacerbations, no exacerbations, so maybe one exacerbation, they are in A or B group, and if they are in the if they have more risk of exacerbations, they are in the COD group. Now, what I want to show you here is now in the 2023 and also 2024 update, the C and D groups have been merged as E groups. So now we don't talk about A, B, C, D classification. Now it is ABE, so ABE assessment now, because C and D are now combined as E. So it's ABE, where E has, so irrespective of despite of the symptoms of COPD, if the patient has a high risk of exacerbation, or there is more than 2 exacerbations per year, or more than one hospital admission, it is categorized as COPD. So similarly, the initial pharmacological treatment also has changed. This is what was there up to 2022. We are in the goal ABCD group. Group A, what we were giving was a bronchodilator, any bronchodilator, either a SABA or a LAMA or whatever. But now, but still in the new guideline also it's the same. In goal A, you can give any bronchodilator. The change that has happened in Group B, previously it was a single long-acting bronchodilator, either a LABA or a LAMA, but now in 2024, they have recommended LABA-LAMA combinations here. So there's no place for single LABA or LAMA. So in Group B, it's LABA-LAMA combination. So as I've told you now, C and D are merged. So now we are talking about single group. Previously for Group C, it was LAMA, single LAMA inhaler, and Group D, LAMA combination. So ICS LAMA combinations were there, but now it's as the two groups are combined, it is again the LAMA combinations that they recommend. But if the patient has high risk of these are the patients who have high risk of exacerbations because they are in the Group E. So what they suggest is do a blood eosinophil level, and if the blood eosinophil levels are more than 300, then you have to go for triple combination. So ICS, LAMA triple combinations. So this evidence came from the ETHOS trial, where ETHOS trial was shown to Here there are patients who are having high risk of exacerbations in COPD. It easily counts of more than 300. Triple combinations which reduce asthma mortality, COPD mortality, as well as the risk of exacerbations. So, the pharmacological treatment now as the steps categories groups have changed. Smoking cessation is there throughout in group A, B, and D, and pulmonary rehabilitation for groups. These are the vaccines that are recommended for COPD. These are the vaccines. But this often changes according to the right. Oxygen therapy hasn't changed much. It's the same. You have to give long-term oxygen in severe hypoxemia only. For moderate hypoxemia, there's no mortality benefit in that. And ventilator therapy, of course, hasn't changed much. That non-invasive ventilation is recommended for the patients, and it was shown to improve survival in patients who are having daytime persistent hypercapnia of over 53 millimeters of mercury. It's the same. The limitations in practicing the new goal, again, like in asthma, now there have been more weight being given for LAMA combinations. Again, there's a lack of availability of LAMA combinations in this country. We don't have them at the moment, really. And LAMA ICS triple combinations also don't have them in single inhalers, but of course you can give them as combined. Availability of vaccines is a problem, and also access to long-term oxygen and NIV. So thank you. I'm sorry I might have eaten a bit of the time for the next lecture as well. Thank you.
One or two questions, sir.
Others, can you please switch off your mic? Please switch off your mic.
I can mute all.
So LAMA combinations were there. There was a combination called intercategory and glycopyrronium combination was there sometime back in the market, maybe around 5-6 years ago, but it was expensive. Certainly not in the government sector, of course. It was in a dry powder form. It was a very good combination, in fact, which we practiced in the UK as well. But I don't think it's available even in the private sector now. No, sir. Like pyrronium and intercategory combinations. Yes, per month. Yes, that's what I told you, sir. Practically, practicing track 1 is a problem because track 1, the preferred reliever and control are both ICS formoterol, either budesonide formoterol or beclomethasone formoterol. Budesonide formoterol preparation, of course, we have in the private sector. There are several brands, we all know they are, so you can practice it. But budesonide formoterol also they are in the private sector, but none of them are available in the government sector. So practicing track 1 in the normal sector, I think there's a problem. But track 2, of course, we can do. In the track 2, the reliever is ICS SAVA. So again, ICS SAVA combinations are also not available in the country. But you can use 2 inhalers, ICS separately and the salbutamol separately, but you have to ask your patient to take 2 inhalers at the same time.
Challenge in the clinical practice is that when we prescribe 2 different inhalers rather than a single inhaler anti-inflammatory reliever therapy, so if it is 2 inhalers, it is actually confusing for the patient.
Yes.
So we say that you have to use whenever you are using the SAVA, often the patients tend to use at a different time, and what they feel is they find a relief when they are using the SAVA, and they don't get a relief when they are using the ICM. And they feel that this inhaler is not working for them.
Very true.
So that is let these 2 non-compliant and we end up using
they have specifically mentioned your this point in the guidelines as well, Araval. They have asked to emphasize your patients that I mean you have to emphasize that it is the same inhaler that you have to use as the reliever as well, because they know that this thing happens. Because psychologically, your patients feel that our control inhaler might not work as a reliever. So they have told in the guidelines that always emphasize your patients that it is a single inhaler, but they have given a practical point there. If the patient is reluctant to use the same inhaler, the control as the reliever, they can use 2 similar inhalers, one in the pocket as a reliever of the same ICS format role, and one for their maintenance treatment. Yeah, there's a point there.
One comment about the COP. As we know from the data suggests that in Sri Lanka the prevalence of COP is about 10% of the population. If you look at the prevalence, almost closer to that of diabetes and hypertension. If you compare the number of spirometrics we are performing for the diagnosis of COP, and if you compare that with the number of fasting blood sugars or the blood pressure performed only for the purpose of diagnosing diabetes and hypertension. So actually, the spirometric facility is the primary care. So now in our country, only available.
Yes, very true. Now this is more emphasized not even in COPD, in asthma as well, because now asthma they always now ask to go for spirometrical diagnosis, because there are a lot of over-diagnosis of asthma as well as under-diagnosis, of course. Yeah, true.
Thank you, Damit, for the very comprehensive, very current update. Before that, I have to make a small announcement. If you have any questions, you can send to the Zoom chat box also. Then we will try to do some answers. Our next speaker is Dr. Sundarlingam, Education Consultant, Respiratory Physician, National Hospital of Sri Lanka. He will be talking to you on TB diagnosis, suspect, investigation, and treatment.
Computer and also microphone both.
Okay.
So 15 minutes, 1 minute, 20 seconds.
Okay, good morning, everybody. So thank you for the College of Pulmonology and Vavuniya Medical Association to invite me to do the talk. So it's, even though the topics mentioned about the TB diagnosis and investigation and when to refer. So we will start with a few common scenarios. It's a young male, okay, a 42 years old male, cough for 4 weeks, feverish feeling, not much fever, and reduced appetite, weight loss, and is working the garment history. So what you will do? So what do you think? So what we will do, it was did X-ray. Okay, so you can see there's a couple of shadows and it's a cavity formation and highly suspicious of TB. Then we will do for the investigation. So it's a second scenario. It's a bit of a difficult scenario. A young child, 3.5-year-old child. Mother complains of child is not active, always a bit lazy, not taking food, as usual. There's no cough or fever, short of breath, anything like that. And the child had a normal birth weight, but at the immunization clinic, the staff was concerned about lack of weight gain. And when questioning further, the mother said the child grandfather had some cough for some time, but he said that's common cold and so. So then child, it's very difficult to diagnose. So what we do, we'll get the growth chart. So you can see the growth was okay for some time, and nearly end of third year, it start to come down. So there should be at least around 3-4 months, the growth, the weight gain is not there. It actually is a weight loss. So you need to know there's something. So we can think about the TB with the chest X-ray. Again, that is normal. So in children, very difficult to get the sputum collection, or we had to go for gastric lavage, anything that's very difficult. But we need to go with evidence. What else we can do? We need the Manto. So Manto is positive. So in continuation with this case, the child grandfather. So he's a 72-year-old guy, he's a diabetic, he's coughing for on and off for so long time. He doesn't want to take treatment as usual. They said, it's due to old age. There is weight loss. He's not bothered about that. But when the child was diagnosed, we got the child's grandfather and did the X-ray. Right? So these are the common scenarios we encounter. So what we can do about that? How can we manage? So I'll come to the topic. So TB diagnosis is a suspect. You have to suspect, investigate, and refer when to refer. So it's a basic thing. The TB is caused by microbial tuberculosis. Others are very rare in here. It's a airborne infection. It's infectious when the infected patient cough or laugh or anything, it goes with a airborne droplet. It's in the environment, and it's when the healthy person inhaled the droplets, he got infected. So in the very good ventilation and sunlight area, the lifespan of the droplet, the bacilli in the droplet is very less. So that's why we are concerned about the working conditions, overcrowded working conditions, and housing. What about the ventilation and all the sunlight? Right. So some data about the global burden. It's a second to the COVID-19, second highest killer in the world. And it's estimated around 10.6 million people fell in. It's a 2022 data worldwide, and it's a very high killer after COVID in the respiratory infection. And then the MDR TB is another important health crisis in a lot of countries. Unfortunately, Sri Lanka doesn't have a problem. I'll come back to that later. And Sri Lanka statistics, what we have in 2023 data, it was around 41.6 per 100,000 people, and all TB cases 9,000 odd, and new one are the 8,000 odd cases. So it's a good data, right? So, and this is a district-wide data. So more in Colombo, you can interpret it in two ways. There are higher population in Colombo, and all the area patients are drained to the Colombo to get treatment. So diagnosis more in Colombo. And also there are a lot of facilities to diagnose compared to the remote areas. So the diagnosis may be high in Colombo, but there can be both way we can interpret. And death rate in Sri Lanka, that is very good. 3.5, that is a good death rate. So why we are worrying about the TB? So this is other data. So you can see here, compared to this is all data. So compared to the other countries in the region, India and Pakistan, Sri Lanka is doing very well better compared to the other regions with a similar socio-economic pattern. So still we are worrying. Why? So now I'm going to present a scary data. So this is the data about the reported cases as well as estimated cases. So the red line represent the reported cases is 29 points, so we will say 30. The lower limit of estimated is 47, upper limit is 84. That means at least we are missing somewhere around 30 to 50% per year. So you can imagine how much the 50% can infect the other normal population. And then the motto of our TB campaign, NTB in 2050, is going to be a dream unless we caught out these patients. So this shows the gap between the estimated in the MDR as well as the TB. So it is even the small letters you can see the estimate gap is around 53% in Sri Lanka for the TB, and MDR is 89%. So we can say our MDR rates are very less. So we can be happy, but when you see the data, we have to do more. So we come to that our presentation. So how can you prevent the TB infections? So it's gone through the breath. So you can ask the patient not to breathe. So how can you do? You have to find the patient early. You have to treat the patient early. Once you start the anti-tuberculosis treatment, in 2 days' time, infectivity is dropped by 85%. And in 2 weeks' time, it almost 97.5%. That means almost it's non-infective. So as how quickly we diagnose the patient and how quickly we treat the patient, that much of quickly we can control the spread of the TB. And then we can achieve the dream of NTB and the gap, cross the gap. So the transmission, everyone knows, I have previously mentioned that it's a droplet transmission person to person, and other transmission is very much negligible amount. When there is a cavitating lesion, when there is a exposure in the indoor, or poor circulation or ventilation, enclosed place, and poor or no access to sunlight, and greater time spent with the infectious person, all are very much increase the infectivity and spread of the TB. So practical difficulties in closing the gap we have to see. One is social stigma. I won't say it's in the rural, even there's some urban areas also, still the patient have a stigma about TB. Diagnosing TB is, even they can be happy with the HIV diagnosis, but maybe sometimes the stigma about the TB diagnosis is still there. They don't want to come to the chest clinic to get the drug. I will come one by one. Then the contact tracing and screening need to be done completely to close this gap. Otherwise, you can't never achieve the full screening. Then difficulty in diagnosis of childhood TB, as my first case I have mentioned, second case. So it's not the straightforward diagnosis like adult patient. And in the elderly patient, there is non-specific symptom and signs. And the third and most, the active case reduction is not adequate in Sri Lankan context. So what is active case reduction and passive case reduction? Passive case reduction, when a patient having a symptom, suspecting he has TB, or someone found that there is some symptoms and refer the patient to a specialist or the hospital, is a passive. Active case finding is, we found the areas where the high chance of infectivity, then we do a mass screening and find out the patient who has possible TB, and to diagnose TB is the active case reduction, like mass screening in the factories, schooling, or some other prison and concentration places, camps, or like that. So those are the active case reduction that need to be escalated to achieve and cross the gap. So about the stigma, patient diagnosed with TB is still a taboo, and patient with symptoms of TB also very reluctant to come to the chest clinic, because one, about the stigma, and second, about they don't know it can be curable or not. Sometimes they think you have to take 6 months drugs, and some patients don't know that drugs are freely given by the government, not for the money. So some rural areas patient doesn't know. So they think, oh, 6 months drugs, how much I have to spend? So they are very reluctant. And the treatment defaulters also happen because of the difficulty to come to clinic and taking time. So if you say a daily worker have a TB, has to come to clinic, means he has to lose the 1 day job, then that will affect his socioeconomic part. So those are the problem here. So how can we close this? We have to give a proper knowledge about TB and spread and prevention, and also have to educate the family and the relations. So most of the time the problem coming from the relations, oh no, don't go to the chest clinic, they will admit you the Velisara or somewhere, you have to be there 6 months. That's a common advice giving from the relation. So we need to educate them, especially not the patient, the relation's family. So then we can, and also we have to mention that it can be 100% curable. So that it need to be emphasized. Contact tracing, household contact and non-household contacts, the workplace, office contacts, and all need to be clinically assessed and need to be done the investigation, basically X-ray and Manto all. And if there are suspicion, we have to go further imaging and other sputum samples, and more emphasis on the patients with immune compromised state, like a elderly patient, diabetes, patient with the immunocompromised drugs, steroid, and patient transplant patients like that. We have to see more carefully. Then childhood TB diagnosis, it's not straightforward. There is no, again, the sputum is gold standard, but very difficult to get the sputum proper sputum sample in the childhood TB. So we have to go with evidence. So what's the evidence? One is mainly the growth chart. So if there is unexplained lack of growth or weight loss for lasting for more than a month or two, always suspect. And you won't get a usual symptom like cough or short of breath or anything. X-ray finding may not be there. If they are a family member having chronic cough, if they are a neighbor having chronic cough or suspected TB, then you have to suspect the child may have TB. Then the Manto is very much helpful in the child, because if with the symptoms and growth and with the Manto positivity, you can assume probably the child have TB if there is no other explanation was sorted out from the investigation. And sometimes it's atypical procedure, some pneumonia not responding to the drugs, sometimes polycontrol asthma or wheeze, and undiagnosed febrile illness, poor feeding, anorexia, weight loss, and children receiving the nutritional treatment, the therapeutic nutritional treatment, or the artificial feed, the artificial formula feed, they are, may not be getting the proper immunity from the mother's breast milk. So they also have vulnerability to get the TB and other fatigue, lethargy, decreased activity or other symptoms. So what we can do, growth chart, first check the growth chart. If there's a weight loss or no proper weight gain, do the Manto, X-ray, if possible take some sputum sample, and also proper history about the childhood illness and the family history and the relations or neighbors having this chronic cough or diagnosed TB. That will give us a clue, is it TB or something else. Then active case reduction, presence inmates of elderly homes. I don't know, Sri Lanka not much have that much elderly home, but if there are others, destitute homes, rehabilitation centers of drug addiction, those are very much immunocompromised. Healthcare workers in high risk settings like MDR, TB wards or laboratories have a high risk. And all the HIV, nowadays in Sri Lanka, all the HIV patients when diagnosed, screening for TB, as vice versa, also all the TB patients diagnosed newly, they are screening for HIV and diabetes. And migrant population or returning refugees also, because even Sri Lanka is first control, the patient can come from outside with MDR, so need to be screened. So diagnosis, we come to the diagnosis. History, examination, and investigation as usual. So history, before history, what are the patients? We need to look carefully and not to miss the diagnosis of TB. As usual, you know, diabetes is not endemic, I would say it's pandemic. It's more than the adult population having a lot of people have diabetes. And it's a common condition, and it's common condition causing immunosuppression. And the patients can have TB with a diabetic, and because of diabetic and immunosuppression, they may not have a classical TB signs and symptoms. HIV infection, yes, second. Patient with a past history of TB or chronic lung disease like COPD, bronchiectasis, or ILD like that, extreme of age, renal failure on hemodialysis, organ transplant. So these patients we need to look carefully. So what are the red flag symptoms? Chronic unexplained cough, unexplained loss of weight or loss of appetite, evening pyrexia, night stress, everyone knows that. Short of breath, sometimes tiredness, fatigability, hemoptysis. It's not common, but it can come with a TB. Then always history, contact history, household contact, workplace contact, non-household contact. Working in the crowded environment or well not aerated or very poorly ventilated environment, like I'm again saying garment factory is a crowded environment like that places, factory workers, history of smoking, previous chronic lung disease or process of TB also need to be addressed. Then the investigation, basic, we start with the imaging, sputum, AFP and gene expert. Gene expert is very high specific and sensitive, but in a follow-up situation, the gene expert may not be useful because even dead bacilli can cause positive. So sputum AFP is the best. Culture is gold standard, but it takes time to come, so you can use the culture for diagnosis part. Then the imaging, chest X-ray, if chest X-ray shows something, but other investigation are negative, then you can go for further imaging, like a CT scan to further evaluate the patient. Inflammatory markers, high inflammatory markers give us some idea. Then about the full fasting blood sugar and the HIV screening also give us the immune status of the patient, and we can substitute our suspicion and make sure that it's TB or not. So this one I have done earlier. So I'll just pass this one. So where can we intervene? So first, the clinical suspicion. So this is for all the doctors, OPD doctors, physicians, the doctors seeing the patient private sector or pediatric side, surgical side, wherever it is. If the patient comes with some unexplained symptom and you suspect the patient having TB, basic investigation, the chest X-ray and AFP can be done at anywhere in the Sri Lankan hospital setting. So that's the basic. Then appropriate investigation. So you go for the basic investigation appropriate. And if it's diagnosed, start ATTB treatment. But if it is not confirmed, right. If it is not confirmed, then refer to a specialist center for further investigation and evaluation. So what are the unexplained symptoms? Earlier, as I again is repeated, cough, weight loss and all, high risk patient, and previous lung disease. Early diagnosis and appropriate referral. This is the one I have told. If the investigation positive, start treatment. If investigation supportive but not confirmed, to a specialist. If the investigation not favoring TB but some other lung disease, investigate for alternate diagnosis. So our role of our clinicians, identifying the red flag symptoms, identifying the high-risk patients, appropriate referral or appropriate investigation, timely investigation, and quick referral or quick treatment started. That will help us to eliminate the TB, and the dream of NTB can come through maybe not even 2050, 2060 or something. Thank you.
Thank you.
Chest X-ray. Because sputum is the problem is the sputum collection and also the microscopy center available. So that is all a lot of dependent on the person as well as the microscopy. So if there is some abnormality in the chest X-ray, and if a diabetic patient abnormal chest X-ray means always there is some chances to find out. So chest X-ray is easy and it's repeatable. Not like a sputum, it's not depend on the person looking in the microscope or depend on the patient giving the, sometimes they will give the salivary sample. So you may get not get the proper sample. So I will say X-ray is easily repeatable and it's more reliable. Yep. So Gene Expert is a DNA assay. It's available in all the government sector. It is a very quick investigation and very specific and sensitive. And also from that we can diagnose the rifampicin resistant from the start itself. So even sometimes the sputum AFP, you need to have some bacilli to find out in the sputum AFP, but even the smaller lot, you can diagnose in the gene expert. So if you have suspicions, always send for gene expert as well as sputum AFP, and it's very specific and sensitive. But again, as I said, it is not useful when the patient on treatment for TB follow up and to found out if the patient cured or not. It may not be helpful because the dead bacilli also can cause positive in the gene expert. But for the diagnosis, yes, it's best.
Especially the specifically the market in children and these.
So Manto, the BCG up to 3 to 6 months, it can cross-react with the Manto test. So children can have Manto positive. So that's why when in the situation like a pregnant patient with a TB diagnosis and positive sputum positive during delivery, we are not giving the BCG immediately. We are starting the INH prophylaxis, and after 3 months only we check the Manto. Then only we go for BCG because that can cross-react. But IGRA, no. But IGRA is very expensive. That means the gamma interferon is very expensive, not available in the government sector. But Manto is mostly reliable, but it can cross-react.
The concept of something postulated by the WHO and our program. That we include more than 3 weeks diagnosis of TB. So that any cough which is lasting more than 2 weeks should undergo investigations to exclude the diagnosis of TB, even if you have an alternative diagnosis. The recommendation, that is a recommendation by the program as well as the WHO. So what do you think the compliance to this recommendation? I would say in my observations, I would say less than 1% of the patients with cough more than 2 weeks are being referred for investigation. So many of the times, many occasions that I observed, many of the patients who are ultimately diagnosed as having TB have multiple healthcare contexts before being first diagnosed with TB.
Okay, so I'll agree with the other one's comment because it's a practical problem in 2 setups. So usually these patients having cough coming to the OPD, but I think the OPD doctors can't order for the X-ray. Is it correct? Clinic and the ward can order, but OPD they can't order for X-ray. They can do the AFP only. So that's a one roadblock to go for the diagnosis because AFP, as I said, it's not reliable in the setup. And second thing, when the patients meet other clinician for some other clinical contact, I don't know, lot of people are very reluctant to go for X-ray. So X-ray is very easily available and it's not much costly. So a simple X-ray will give you a diagnosis or will you are confident that patient doesn't have TB. So that is, I don't know, maybe with the busy, because in the clinic setup, how many patients we are seeing, at least around medical clinic, maybe hundreds or something. So each and every patient, when you are discussing and asking the X-ray, it's difficult. But at least I think our campaign recommendation is at least 5% OPD patient has to be referred to the microscopy center. But making X-ray availability for the OPD is better than that, I think. And it's very much less hassle-free and repeatable test. And I agree with the comment of Adam, yes. Okay, yeah. Thank you.
I already mind the bill will go at 15 minutes and 20 minutes, and then the question time will start. Our next speaker is Dr. Dinesh Avalsingh, a consultant respiratory physician and senior lecturer in the Physiology Department, University of Luguna. And she will be and she'll be talking about non-invasive ventilation clinical practice.
Thank you, sir, for the kind words of introduction. And I would like to take this opportunity to thank the Vavuniya Medical Society as well, sorry, Vavuniya Medical Society as well as the Sri Lanka College of Pulmonologists for inviting me to deliver this lecture. Right. Today, my talk will be on non-invasive ventilation in clinical practice. If time permits, I will try to talk about some practical aspects on setting up NIV, monitoring, and looking after them after putting them on NIV as well. So my talk, the outline of my talk will be what is non-invasive ventilation, for whom is NIV, the terminology, and also the different modes of NIV, and how to set up and monitor your patient. Right. So this ventilation is of two types, the negative pressure ventilation and positive pressure ventilation. The initial non-invasive ventilator was a negative pressure ventilator. As you can see here, the tank ventilator, which was used in the polio pandemic, where you put the patient inside a tank, create a negative pressure inside, the head stays outside. So because of the negative pressure inside, the lung has a more negative pressure than the atmosphere. So through the mouth, air comes in and then goes out, right? So that was the initiation of the non-invasive ventilators, but then now we have positive pressure ventilators of two types, the pressure preset ventilators and the volume preset ventilators. And invasive and non-invasive ventilation, I don't want to tell you the difference of it. Invasive is where you put a tube inside, either through your mouth, nose, or your trachea. And non-invasive is where we give ventilation through a mask interface. Right, so why NIV in the acute setting? Right? So NIV has shown to shorten the admission length, reduce mortality, reduce morbidity, and reduce the need for intubation in patients with acute respiratory failure. And there is ample evidence to support this. And the guidelines, the ERS ATS guidelines, recommends NIV for patients with reversible acute hypercapnic respiratory failure. If I go to individual diseases, we can see that COPD, which has the largest amount of evidence, if the pH is less than 7.35 and your PCO2 is more than 6.5 with increased work of breathing. So this respiratory rate more than 23 means increased work of breathing. So why in COPD? So usually we know we take it respiratory rate more than 30 is tachypnea. But here in COPD, the respiratory rate cutoff taken is a little bit less, because we know when your carbon dioxide levels go up, your respiratory rate centers are so you are not conscious, your drowsy level, your conscious levels reduces, and then we take a lower respiratory cutoff for the tachypnea in COPD patients. Then when it comes to neuromuscular disease patients, we use NIV in acute respiratory failure if the respiratory rate is more than 20 with low vital capacity, pH is low, and PCO2 is still high. We can use it in obese patients as well, in obesity hypoventilation, where we find their PCO2 is high as well. And NIV is not indicated in asthma patients to use in a ward setup, right? So not indicated in asthma patients. And also, even though we use in COPD exacerbation, if your patient is normocapnic, that is, they don't have, patient is having hypercapnia, but the pH, not non-acidotic, right? pH is within the normal range. There is no clear benefit in using NIV in terms of reducing morbidity, mortality, or time to need for intubation. So it is not recommended if your patient is not acidotic, right? Okay. Right. So should NIV be used for acute respiratory failure due to cardiogenic pulmonary edema? So there is clear evidence that it can be used in patients with cardiogenic pulmonary edema, and we can use either CPAP treatment or even BiPAP ventilation for this group. And the research has shown that it reduces mortality and decreases the need for intubation in these patients. But the guideline does not recommend it for patients with acute coronary syndrome or for patients with cardiogenic shock. The simple reason is this group of patients has not been included in the research study. And also there is some degree of evidence that patients on NIV have a slight higher degree chance of developing cardiac chest pain or ischemic events. So even though it is not solid evidence, there are some degree of evidence. So that is why these two groups have not been studied for acute NIV. So you can use in cardiogenic pulmonary edema, but not when your patient is in cardiogenic shock or having acute coronary syndrome. Right. So this is what I told before, not indicated in asthma or pneumonia. So if your patient has asthma, pneumonia, and the patient is in respiratory distress, the becoming acidotic with high carbon dioxide levels, refer to ITU, right? Needs ITU for early consideration of invasive mechanical ventilation. Now, there is evidence for use of NIV in these groups of patients, post-operative acute respiratory failure, acute respiratory failure immunocompromised, and in palliative care as well. But these are all conditional recommendations with moderate certainty. Okay, so when not to use NIV? So those are the places where we can use, but though we can use in those situations, we will have to always look for the absolute contraindications and relative contraindications in NIV before initiating treatment. So what are the absolute contraindications? If there is an undrained pneumothorax, you should not start your patient on NIV unless there is a chest tube in place, which is functioning, right? And facial burns, fixed upper airway obstruction, and post-esophagectomy for at least 2 weeks. So with the facial burns and fixed upper airway obstruction, the mask interface application has a problem, right? And relative contraindication, if your patient GCS is less than 8 and the pH is less than 7.15, confused, agitated, there is cognitive impairment and vomiting. Those are relative contraindications for NIV. Having said that, the GCS less than 8, purely due to increase in carbon dioxide level in COPD, there is still a place to try NIV as first before going for intubation. Right, so you should know the indications for ICU referral, because then you know when you should stop and refer for ICU in your patient. Now, when you're setting up NIV, right? So some of you will be familiar with, but some of you will not be. So let's go to the basics where you cannot talk about NIV without knowing the respiratory cycle, which we use in terms of the machine given names, right? So trigger is the initiation of inspiration felt by the machine by either a change in the flow when the patient is breathing, change in a volume, or it can be by a time trigger. The machine can be set. Now you breathe. Let the patient inspire. Right? So when this trigger happens, the pressure in your machine increases to the inspiratory pressure, the IPAP. Right? So this is, and during this period, the patient inspires. And then there is something called cycling, where the patient wants to exhale, right? So what is cycling means? This is the point where the change in the flow or the pressure or the time is detected by your machine, and this shifts from inspiratory mode to expiratory pressure, right? So the machine shifts to expiratory mode from inspiration here. So pressure drops down to the PEEP, right? So this is the IPAP, this is the EPAP or the PEEP, right? Okay, so these 4 terms you should know when you are setting your ventilator. And expiratory time, right? So in expiration, I told you there is a PEEP or a slight positive pressure applied. And the reason for that is it will allow the circuit to get rid of carbon dioxide as well, and also improves the functional residual capacity of your lung, and oxygenation also is improved because it will open up the collapsed alveoli and reduce left to right pulmonary shunting as well, right? So in addition to that, if your patient is obese, they might have underlying or obstructive sleep apnea as well. So PEEP is important in that as well. Right, the common setting parameters, I told you the EPAP or the PEEP, IPAP or the inspiratory positive airway pressure, and the difference from IPAP and EPAP, we call it the pressure support, right? And then the inspiratory time, the machine sets the minimum inspiratory time to allow alveolar ventilation. During this minimum inspiratory time, even the machine, the patient wants to exhale, your machine will not allow the patient to exhale until TI min is reached. That is to make sure that the patient gets enough air in. And TI max is set where at this point, even the patient still tries to inspire, your machine will tell you, no, here you got to expire now, right? And it will allow expiration and prevent air trapping in the patient, right? So the TI is the actual inspiratory time of your patient, right? So those are the settings, and there are very specific settings where we can use for patient comfort. The rise time, that is from EPAP, how much time it takes for the machine to reach the IPAP. Then the fall time is from IPAP, how much time does the machine take to drop to the EPAP, right? So those are terms what we can use to use for patient comfort and various settings. And that should be done if you know what you are doing, right? Okay, right. So then the IPAP, so the pressure support, right? The difference from IPAP and PEEP is assisting in inspiration, and the EPAP, I told you, helps in oxygenation. So if you want to wash out carbon dioxide, you should meddle with your pressure support, right? If you want to increase oxygenation, you will have to increase your PEEP, right? But make sure increasing your PEEP, you will not reduce your pressure support in a patient who has adequate carbon dioxide washout, right? So if your adequate carbon dioxide washout, you need to increase your PEEP, increase your IPAP by the similar number. Right, so there are common ventilatory modes. You get all of these. I heard from Sachini that you have Stellar machines here. So these are the modes you see in a Stellar machine, right? The CPAP mode, these are all BiPAP modes, the spontaneous timed pressure assist control, and the intelligent mode, the IVAPS mode. What is CPAP? A fixed pressure is delivered. It does not vary with patient's inspiration or expiration, and the patient inspires and expires, right? So spontaneous mode, the patient needs to trigger inspiration and expiration. If the patient does not trigger, your machine will not deliver. So do not use spontaneous mode in your ward for acute patients. If your patient stops breathing, machine will not deliver. And if you do not look at the patient, you will find the patient with rigor mortis. Right. Okay. Right. So then spontaneous time is what we recommend to use in acute setting, where if your patient, there is the patient spontaneously breathe, machine supports. If the patient stops breathing and the backup rate, we set a backup rate, it is not maintained, the machine would deliver a breath. Okay. And timed mode, the machine will not care what the patient does. It will deliver, you inspire, you expire. Patient will try to inspire, expire, machine will just ignore. So we are not using this mode unless your patient is paralyzed and ventilated. Okay, I will not go into these two modes, right, which are quite, this is an intelligent mode. This is similar to the ST mode, right, but the cycling happens due to a time trigger. Right, now when you're looking at your machine, right, this triangle gives you an idea that this is done by the machine, right? If there is a human being at the top, that means it is by the patient's trigger, right? Okay, so a brief thing. So what mode do you think this is? This is the patient's effort. This is the pressure given by the machine, and this is the flow taken in. So you can see there is patient effort. There is continuous pressure, no change, and the patient breathes in and out. And according to the effort, the flow going in changes. What mode do you think this is? So the pressure does not change. CPAP mode, very good, right? Okay. Now next thing, right? You see here, patient triggered, patient cycle, patient triggered, patient cycle, patient triggered, machine cycled by the T at TI min. Here the patient is triggering, it's machine cycled by TI max. The effort is very high, but passes TI max, so the machine is cycling it to expiratory mode. Here there is a pause and there is no delivery by the machine. What mode is this? Spontaneous mode. Excellent. Right. Right here, patient triggers, patient cycles, patient triggers, cycling at TI min, patient triggers, sorry, machine triggers, machine cycles, patient triggers, machine cycles. This one, ST mode. So when there is a pause in your patient's effort, the machine will deliver until the backup rate is reached. Okay, right. So this is the pressure assist control, what I told you, PAC mode, where patient triggers but the machine cycles, right? Similar to ST mode. I also don't know what is the clinical significance in this mode, right? I don't think it will be very comfortable for your patient anyway. Right, so this mode, patient tries to breathe, not detected. Patient, the machine triggers, machine cycles, machine triggers, machine cycles, equal intervals. Yeah. So patient effort not considered, but it will, machine is giving a breath, exhaling, inhaling, exhaling, timed mode, right? Okay, right, good. Now when we are going to, let's moving on to NIV setup, right? We need to find the appropriate mask type, right? So select an appropriate mask type, and in your machine setups, in the setup menu, there is a place to select the mask type in the menu in your machine. So select that, and usually we start in ST mode. IPAP pressure 10 and 4. You can start with 10 and 4, and then you can gradually increase initially to maintain adequate alveolar ventilation or tidal volume and maintain the saturation, right? So sorry, you can go up in the pressures, right? Accordingly, usually we go up in EPAP by 1 and IPAP by 2, right? And do not exceed 30 for IPAP usually and 8 for EPAP usually, right? Okay, so I told you we can change the rise time, right? This is the machines. The Stella has programs for different pathologies. So that different pathology usually uses these ratios. You know, in COPD, we need more time to expire. In interstitial lung disease, you would need more time to inspire, right? So those are slightly set at your various pathologies, but still you can change it. And we do a blood gas after 1 hour, after we change a setting, right? Then 4 hours, okay? Right, so what is the investigation you need to do before starting NIV? ABG definitely we'll have to do, because otherwise we don't know your patient is in type 1 or type 2 failure. Other than NIV, ABG, chest X-ray, right? We should not put it in a undiagnosed pneumothorax patient, right? Excellent, right? Next. So mask interface, I told you there are various mask interface, but in an acute setting, full face mask or the oronasal mask is what is recommended, right? So sorry, full face mask here I have shown it for this mask, right? This mask is called the full face mask, but in Sri Lankan setting for the oronasal mask, we call it full face as well, right? So this is the mask what we recommend. We can use this as well, but not the nasal in an acute setting. Why? Because patients who are in severe acute respiratory failure usually breathe through their mouth. So there is no point in putting a mask around your nose when your patient starts breathing from your mouth. Humidifier is recommended, right? So make sure that your humidifier chamber in your Stella machine is having adequate water, right? Okay, what to look in the screen? Look at the leak. The leak should be less than 25. This is the inspirator time, then the tidal volume. So, you know, there is something called dead space, right? Which is roughly about your body weight in pounds, right? So if this tidal volume is about 120 milliliters, that means nothing is, in a patient who is about 120 pounds, nothing is going into the alveoli. It only ventilates your dead space. So you need to have a ideal tidal volume, ideally at least about 6 milliliters per kilogram body weight, ideal body weight, right? Okay, monitoring, I told you, you should have a continuous cardiac monitor. Saturation should be monitored continuously for at least 12 hours. You should look for a reduction in your carbon dioxide, oxygen increase, and your saturation should be, target saturation should be achieved, right? So if your PaCO2 remains high, you can increase your pressure support or increase your tidal volume, right? And if the patient remains hypoxic, we usually increase the IPAP, or we can entrain oxygen into it. So to entrain oxygen, there are methods. So use an appropriate method rather than using a nasal cannula on top of your mask, which will cause additional leakage. There are newer masks coming with grooves for your nasal cannula or your NG, but we don't have that luxury in the state sector. So probably go for an adequate method of entraining oxygen into your mask. Now, moving on to a bit of practical things you should know. Before you set up an NIV for a patient, please do explain to your patient that this is going to be put here. We will put it not too tight, right? But you need to keep this in place, and this will help to keep your airways open and help you to breathe, right? So then the patient's compliance or the tolerance to this NIV will increase, or otherwise the patient will tell, no, I don't want to use it, or they will just remove it and throw it away, right? And there are side effects. So there will be drying of your nose and mouth because it's high pressurized air. So coming at a high flow rate. So there will be drying. Nosebleeds can occur. Some of the air can go into your tummy as well, and bloating can occur, right? Even in UK for bloating, they use peppermint water. I don't know whether it worked well or not, but that was what they were using for bloating, right? Right. And ear or sinus discomfort can occur. Eye irritation with air leaking into your eyes can happen. You can get skin rashes as well. If your mask is too tight, you can get injury at the bridge of the nose. So make sure your mask is not too tight. Practically, I would ask my patients when I set them up on NIV immediately after, is the mask too tight? Then I will ask, does the machine deliver breaths adequately? That means when you want to inspire, does it give you enough flow, right? Or is the flow reduced? And then I will ask, right, when you are inspiring, does the flow stop early? That means your inspiratory time is not enough. So the patient needs a little bit more air, right? And then when you are trying to exhale, does the machine still push air in, right? So that means the inspiratory time can be adjusted a little bit, but if you can't go below your TI min or TI max, but still we can adjust them a little bit. Right, now just that was all about acute setting, right? And then weaning off, usually we come down in the times of using the NIV rather than coming down in pressure. In invasive ventilation, what we do, we come down in the pressures. But here we tend to come down in the time duration. We give breaks, reduce it during the daytime, continue at night time, then only we gradually wean it off. Okay, and then there is a place for huge place for home mechanical ventilation in chronic patients, right? This is just the definition of home mechanical ventilation. And for whom is it? We can use in obesity hypoventilation patient and or severe obstructive sleep apnea. Here we use CPAP, here we use BiPAP, right? And these are the cutoff values, you should know them, right? Because we don't put it for patients less than these values. And in COPD, symptomatic hypercapnic patients, that means PCO2 levels should be above 52.5 millimeters mercury or 7 kilopascals. And we use it for patients who have had 2 or more hospitalizations needing NIV, right? So if your patient comes one time, needed NIV, second time, needed NIV, refer to your respiratory physician or your respiratory colleague. If the patient comes after even the first episode and you cannot wean them off the NIV, they may be potential candidates for home NIV, right? So sometimes we send them on home NIV, get them back after 3 to 4 weeks, reassess, really do they need to use NIV or their oxygenation and carbon respiration has improved or not. There is a place for patients in neuromuscular disease, chest wall disorders such as scoliosis and post-poliomyelitis. In patients with daytime hypercapnia, but most importantly, symptomatic nocturnal hypoventilation. So if you use NIV for this group of patients, when they have daytime hypercapnia, there will be a symptomatic benefit. But if you catch them early, where they develop nocturnal hypoventilation and put them on NIV, there will be a mortality benefit as well, right? So if your patient has a saturation of less than 92, right, chronic patient, refer them for assessment for domiciliary NIV or CPAP treatment. So in obstructive sleep apnea, there is a definite place, right, to use CPAP treatment. And evidence is coming from since 1999. Even though we started it last year to give machines from the state sector to patients, sorry, not last year, this year, right? Okay. So the evidence comes from 1999, where there is a muscle hypothesis and sleep hypothesis. The muscle hypothesis is non-invasive positive pressure ventilation is resting the chronically fatigued respiratory muscles and therefore improving your respiratory mechanics. And also sleep hypothesis prevents sleep disordered breathing. You know, there are a lot of people with COPD, OSA overlap, bronchiectasis or OSA overlap. So this group of patients will benefit because their sleep disordered breathing is also treated as well. Okay, so in summary, chronic type 2 respiratory failure, you can use NIV, especially COPD, obesity hypoventilation, neuromuscular diseases, right? And when we are starting, you start for a higher EPAP for patients with obese OSA, or otherwise, if they are non-obese, thin patients, you start with a 4 EPAP, right? And up titrate to maintain or achieve the targets in tidal volume, blood gas measurements, the respiratory rate should come down, the work of breathing should come down. In addition, the patient should be comfortable as well, right? So the patient, you should not just tie their arms and legs, fix them in a very tight mask, right? Because recently I'll tell you a story, a patient, this is not what happened to me. for someone else, I can't remember who, had gone to see a patient who had been tied and put on a mask, and to talk with the patient, that mask had been removed, and the patient had told, Mahatyata, Budu bawa attenawa meka galawa. Right? So don't go to that level with your patients. That's why I make it a habit to ask those 4 or 5 questions regarding that patient comfort as well. So your machine should do what it's supposed to do. If you are, and the patient tolerance will improve if you are maintaining patient comfort as well. Right? Okay, I think that's all. Thank you.
Thank you for taking 30 minutes. Any questions? No?
We know even without the situation patient can manage it. So they suggest about sort of pressure and about some patient to select and to problem that they can't find.
Yes. So now, when the patient comes to you with respiratory distress, respiratory rate is high, right? You know that they have COPD, or even if you don't know, the saturations are low, you check for the saturation. So when the saturation is low, you go with the blood gas, right? So with the blood gas, then you can identify what type of respiratory failure. Is it type 1 respiratory failure or a type 2 respiratory failure? And remember, as I told you, look whether there is acidosis as well in your patient, right? The pH should be less than 7.35 for you to put on non-invasive ventilation, right? Have a card with the indications in different diseases for NIV in somewhere in your ward, right? And then, as I told you, the starting pressures, usually if your patient is thin built, you don't think they must be having obesity or sleep apnea, you start with the EPAP of 4, IPAP of roughly around 10, right? So then look at your patients. I told you to look at that lower bar where their tidal volume is. So when the tidal volume, if it is, I told you the body weight in kilos times 2 is your dead space ventilation. If you now we don't measure the patient in pounds, no, the idea correct value is in pounds, so otherwise you'll have to multiply it by 2.2, so roughly go by 2, and that ventilation is dead space, and there should be additional ventilation going in that tidal volume or the VT value, right? So look at that and see whether your patient is maintaining the needed saturation target. If this is a chronic type 2 respiratory failure found by the bicarb, you'll capture bicarb. If the bicarb is high, then you know this is a chronic type 2 rather than an acute type 2 respiratory failure. So in that case, the target saturation 88 to 92, right? If the patient is maintaining it in that level, then and repeat the blood, you keep the mesh patient on that treatment or BiPAP treatment for about 1 hour, and then repeat the blood gas and see whether what you have done to your patient is improving his condition or not. But during that 1 hour, you can look at how your patient breathes. Respiratory rate slowly coming down. The distress, the patient is using accessory muscles, abdominal muscles for breathing, and those also will gradually come down. So that is what I would recommend for you to start with, and always don't hesitate to ask your senior, right? I know that nowadays, during our times also, the consultants were quite friendly, but sometimes the consultants are quite scary. But nowadays, the consultants are very friendly, right? And you can always call them. During my student time, you could never call a consultant, right? But now we can call them and tell, look, this patient has come and this is what I have done. The repeat blood gas is this. Can you suggest me what else to do, right? And also have in your card the contraindication list. and the indications for ICU to contact. And don't wait till the indications are for ICU are worst, right? So at the immediate point, you call the ICU colleagues and tell, look, there is this patient whom we have started on NIV. If he improves, then we don't need to send him to ICU. But if he deteriorates, in my next assessment, I will contact you, right? Then all the teams are aware. So I think that is a good practice point for everybody to start. Have that. So if you don't remember everything, have it in a card. Indications, contraindications, what investigations I should order, and what are the indications to send them to ICE. So I think starting there, and when I was a senior registrar with you, sir, I remember we meddled with our NIV, and that's how we learned. There was no one to teach us because it was quite new. And luckily I had you, because you had a good knowledge in the physiology and what happens when with these numbers in the machine. And then we got various trainings, and it came to a level where we were better than the people who came to train us at the start. So anybody can master it if you are not scared and you are interested in doing it. Thank you.
Thank you, Dr. Mahi Gunasekar, for chairing the first half of our session. We've reached the end of the first part of today's program. We will now be breaking for 10 minutes, and our session will roughly be begin at around 11:40.